Welcome to part 2 of our point-of-care musculoskeletal ultrasound series for joint bleed detection. This module comprises a number of interesting case studies. My name is Annette von Dregalski. I'm an associate clinical professor of medicine and the director of the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. Abbreviations used throughout the module will be POC for point of care and MUSCUS for musculoskeletal ultrasound. This module is designed to sharpen the diagnostic acumen to detect simple and complex joint effusions, and we begin with effusions in the knee. The first case is a patient with severe hemophilia B, severe arthropathies, and a replaced knee who comes to clinic with acute right knee pain and swelling. Point of care ultrasound performed. Here longitudinally in the suprapatellar bursa and also the medial recess demonstrate a large complex effusion present in both places, most suggestive of hemarthrosis. Also visible is some power Doppler signal surrounding this effusion in the soft tissue, indicating abnormal vascularization, most pronounced at the medial aspect of the patella. Subsequently, an ultrasound-guided aspiration was performed for pain relief and also diagnostic accuracy after 1 dose of factor IX replacement. Visualized here is the suprapatellar bursa in transverse axis, and here you can see the needle in the fluid. Fluid withdrawal yielded about 10 milliliters of a bloody effusion or frank hemarthrosis. And as you can see in the immediate after control scanning, the medial recess as well as the suprapatellar bursa were dry tapped. I'd like to point out this area here demonstrating hardware with comate shadowing underneath, very typical, and also here this is a piece of hardware. This patient returned 3 days after his acute bleeding episode and daily treatment with factor IX for a follow-up scan. The ultrasound here in the suprapatellar bursa and again the medial recess demonstrate that there is no new fluid, no new hemarthrosis. It remains dry tapped. I would like to point out again the hardware piece with comate shadowing underneath here and also here. However, what remains visible is a pronounced, if not augmented, power Doppler signal in the soft tissue adjacent to the hardware and the patella. This is of concern since it indicates abnormal vascularity, vascular remodeling, often associated with leaky vessels, possibly predisposing the patient to rebleeding, especially during the rehabilitation period with mechanical stress. As good practice in internal medicine, fluid analysis was sent to rule out other causes underlying the hemarthrosis. The analysis came back negative for gram stain, for cultures, for crystals, and also a very low white count was noted, altogether consistent with the notion that the hemarthrosis was solely based on the underlying hemophilia condition. The teaching points here are several. Namely, aspiration may be a tool to provide immediate pain relief, and the evacuation of the hemarthrosis did not result in rebleeding with the benefit of the immediate pain relief. And the augmentation of vascular changes observed by power Doppler signal may predispose to rebleeding because of the leaky vessels and warrant some caution, especially in the immediate rehabilitation period, maybe avoiding too much of mechanical stress, or in children avoiding too early mobilization with running and jumping. This is our second case, a patient with severe hemophilia A. He has also severe arthropathies, also a replaced knee, and also comes to clinic with increased right knee pain and swelling. In contrast to the first patient, though, this patient does not think that he is bleeding. He believes he has arthritis pains. We also performed a point-of-care ultrasound, here longitudinal of the suprapatellar bursa and then his medial recess. and had the benefit of having baseline imaging performed 1 year prior on hand, showing a small amount of anechoic simple effusion in his suprapatellar bursa and also in his medial recess. You can see here a very undulating and irregular patella. This is the femur, and the same here, patella, irregular, some hardware with comate shadowing, and here the femur. Now, during the acute painful episode, you can appreciate that in both areas, suprapatellar bursa and the recess, there is much augmentation of the fluid, and at least here in the suprapatellar bursa, easily recognizable, a lot of speckles and material indicating a complex, most likely bloody effusion. Shown here are the compression movies of this patient, suprapatellar bursa, lateral recess and medial recess. And the teaching points here are that the recesses are not fully compressible. They are only partially compressible, mostly because they are filled with such a large amount of fluid. You can also appreciate that the, again, appearance of the fluid is complex with somewhat displaceable speckles and material. So again, this is suspected hemarthrosis. As in the first patient, we continued to ultrasound-guided joint aspiration for 2 reasons. 1, diagnostic purposes. 2, to provide immediate pain relief. Here you see fluid accumulated in the suprapatellar bursa, this time imaged in transverse axis, and the needle approaching a very thick capsule that almost appears bone-like, here demarcated by this sharp white line. The needle had to be advanced through the capsule, which caused the patient some pain. Very unusual to have such a thick capsule. And then finally seeing the needle here in the fluid and aspirating about 80 milliliters of frank blood. Now, fluid analysis yielded also negative gram stains and negative cultures, really important in replaced knees. One always has to rule out infection. Negative crystals and a low white count all together, again reassuring that the hemarthrosis was most likely predisposed only by the underlying hemophilia, plus minus other causes such as mechanic irritation. Towards this end, the patient was sent for orthopedic consultation to rule out hardware failure or other orthopedic reasons for this large, impressive hemarthrosis in a patient who usually uses factor VIII prophylaxis. This image then shows us the post-aspiration scan. Here, suprapatellar bursa and medial recess, in essence dry tapped, compared to the previous large hemarthrosis in both areas. The third case is a patient with mild hemophilia A and an inhibitor who presents to clinic with increasing left knee pain and swelling. And as in the previous 2 patients, point-of-care ultrasound was performed, here showing the scan of the suprapatellar bursa and longitudinal axis. Again, in this patient, we had the benefit of a baseline scan that shows absent fluid in the suprapatellar bursa. During the acute episode, there is some mild fluid accumulation here in the bursa and possibly a complex effusion. Difficult to say. This might be soft tissue frons. So to confirm, after 1 dose of bypassing agent, also an acute ultrasound-guided joint aspiration was performed. Here again showing the suprapatellar bursa with fluid in transverse or short axis. Unlike in the previous 2 patients though, you can see that needle aspiration yielded simple serous fluid. There is no hemarthrosis present. So the teaching points here are, first, soft tissue frons can mimic a complex effusion, and if not sure, it might be better to aspirate. And the aspiration was really instructional for patient and physician likewise, since the patient was relieved to see absence of hemarthrosis and no need for factor replacement. Since we have talked much about aspiration as part of the management of the first 3 patients, this is a demonstration of the knee aspiration position under ultrasound guidance. This is typical and a lateral approach into the suprapatellar recess, or interchangeably called bursa. The next 2 cases will address ankle effusions. Case number 4 is a young patient with severe hemophilia A. He is 24 years old and he presents to clinic with subacute pain after twisting his right ankle. Point of care ultrasound was performed, showing here the transducer position in transverse or short axis and here in long axis to visualize the tibiotalar joint space. To the right, in short axis, this line here would represent the bone. This here is capsule and fat pad, and the joint space is filled with complex fluid. Similarly, fluid is visualized in longitudinal axis. This line here representing the tibia with talar dome and fat pad. This slide here depicts the continued case number 4 with resolution of bleeding several weeks after the initial episode and then with rebleeding several months later. Here in the panel to the left, you can see the original images as shown in the compression movie in the slide before during the acute episode, again in transverse or short axis and long axis visualizing the fluid-filled tibiotalar joint space. Several weeks later, the situation has resolved. You can see that there is now a small narrow line representing the joint space, and the fat pad here in longitudinal axis has returned in its place. However, several months later, he presents again with a new large effusion, and this presentation is several days after he has administered daily factor VIII concentrates. And now you can see this vast space filled with mixed echogenicity in short axis as well as in long axis. And these mixed or complex echoes had little compressibility and represent clotted blood and hematoma. The takeaway teaching points from this case number 4 are 2. First, after treatment with clotting factor, blood coagulates and can become non-compressible, exhibiting characteristics much like soft tissue. Also, and second, blood clots seem to be heterogeneous in their appearance. The echogenicity patterns of evolving blood clots are not yet studied and fully understood. Case number 5 is also a young patient, this time with moderate hemophilia A, and he presents to clinic with severe right ankle pain after waking up in the morning. He received Muscas within 3 hours, and encircled in red you see the painful ankle joint, and I believe you can appreciate that there is little swelling, redness, or any other finding or symptom that would predict if there was hemarthrosis or not. This slide depicts the acute images taken with ultrasound compared to the patient's baseline. Patient's baseline is shown to the right, the ankle joint in transverse axis and in longitudinal axis. In both cases, the joint space is normal. Here visible is a small black stripe in transverse axis, and this would be the joint space in longitudinal axis, tibia, talar dome, lined by a stripe of cartilage and the fat pad in place. During the acute episode, the joint space widens quite significantly, filled with complex material, and the same is visible in longitudinal axis with displacement of the fat pad cranially. Here we see the compression movies of the ankle joint during the acute painful episode in transverse axis on top and in longitudinal axis on the bottom. Please note that in this case there is not full compressibility, maybe just partial compressibility, and sometimes this is a situation if there is a massive effusion and most of the joint space is occupied by either bloody or non-bloody fluid. It might be somewhat more difficult to compress. We then proceeded to aspiration, taking the so-called medial approach. We felt it was important, given that this was the first ankle pain in a 21-year-old with moderate hemophilia. So we wanted to confirm the diagnosis and also provide immediate pain relief. So here you can see the needle advanced into the joint space, and we managed to aspirate around 10 milliliters of frank bloody fluid. Shown here is one of these syringes. In terms of therapeutic effect, the patient had immediate pain resolution from a visual analog scale of 7 out of 10 down to 1 out of 10, and he was able to walk normally and down the stairs, whereas he hobbled and needed assistance before when he came to see us in clinic. This slide depicts a series of ultrasounds performed in this young patient before, during, and after his bleeding episode. So taking you through this, here would be his baseline, again in transverse axis and here in longitudinal axis with a normal small joint space. Here is tibia in longitudinal axis, talar dome with a stripe of cartilage and fat pad in place. This changes dramatically during his bleeding episode with a widening of the joint space seen in transverse axis and also in longitudinal axis. This will all represent complex bloody effusion. And then several hours post-aspiration, a repeat scan was done, and you can see that he was in essence almost dry tapped with no more fluid visible in the transverse axis, and maybe some residual fluid or possibly hematoma. It's now several hours after aspiration and factor infusion, still visible in longitudinal axis. The most important take-home or teaching points from this case are as follows. Comparative baseline joint scans are very useful in the detection of hemarthrosis. Hemarthrosis can be present despite absence or swelling or other findings such as warmth or severe range of motion deficits. And very importantly, small amounts of blood, maybe few milliliters in smaller joints, can appear as a large effusion on ultrasound because of high tissue resolution and magnification inherent to the technique. Aspiration can provide immediate pain relief and may be beneficial therapeutically. The next two cases will exemplify the detection of effusion in the elbow joint. This first slide pertaining to joint effusions in the elbow just demonstrates that ultrasound can visualize really small amounts of joint fluid. This here is my elbow, a normal elbow imaged longitudinally at the olecranon. This is the humerus, this is the olecranon, this is the joint space, and this is the olecranon fossa, containing a small amount of simple anechoic physiologic joint fluid, maybe 1 milliliter. With the fat pad visualized on top, it is in place, not displaced. With joint effusions, as we will see, this olecranon fossa often fills up with the fat pad displaced cranially. The next three slides will take us through a severe hemarthrosis in the elbow joint. This is a patient with severe hemophilia A. He comes to clinic with acute elbow pain. He is 36 years old and on regular prophylaxis. His elbow here imaged in short axis or transverse axis anteriorly demonstrates a small and narrow joint space at baseline. This line would represent the bone. This line would represent the capsule with a small stripe of cartilage in between. During the acute episode, this joint space is widened with the presence of complex material, especially visible in this area. And you can also appreciate here a small or thin line, a so-called interference sign, separating the cartilage, here lining the bone, from fluid on top. In longitudinal axis, the effusion shows as follows. At baseline, you see the patient's humerus, a not quite normal radius, with maybe some small amount of fluid visible in this axis. You see that the capsule here is somewhat lifted and leaves a small area with some anechoic fluid present. However, during the acute episode, you can see that this capsule is further extended with now accumulating complex fluid underneath, covering the humerus and accumulating here in the radial fossa. It is always advantageous to look in all three axes for fluid, because sometimes due to loculation or complicated elbow anatomy, and that is true for every joint, effusions might be more visible in one location than another. So here we proceed to the posterior axis or longitudinal olecranon axis, and you can see that the patient at baseline has some mild fluid present, but again, it is not much. The fat pad or capsule is in place and it might truly be physiological. However, during the acute episode, you now can appreciate the accumulation of lots of complex material in the olecranon fossa with displacement of the fat pad, indicative of a large hemarthrosis. The next two slides take us through case 7, also severe hemarthrosis in a patient with severe hemophilia A. He experienced acute elbow pain after a ball game. He is 28 years old and also usually on prophylaxis. So here we just see images in two axes and start with the long axis, the humeral radial joint. Again, in this patient we have a baseline, which is always helpful in terms of evaluating acute painful episodes. And you can see here the humerus and remnants of the radius, again, a not completely normal joint. This would be the fat pad in place, and that is the capsule. So visible here, probably some mild fluid accumulation even at baseline. During the acute episode here, the capsule is now extended quite a bit with more fluid accumulation here in the area where previously there was a fat pad visible. This fat pad is pushed cranially, and the ecotexture of the fluid appears to be complex. To confirm the hemarthrosis, a posterior scan is performed here in longitudinal axis at the olecranon. At baseline, you can see that this patient already has either some soft tissue proliferation or maybe even a mild amount of fluid, just as visualized here in long axis in the elbow joint. However, the fat pad is not dramatically displaced. During the acute episode, you can see that the olecranon fossa here widens quite a bit compared to baseline, with more material hypoechoic to complex in echogenicity accumulating in this area. So this episode most likely represents hemarthrosis. The last few slides will be devoted to some clinical pearls and clinically important aspects when performing ultrasounds for joint effusions. So first, again, a few words to explain the interface sign in more detail. The interface sign can be a real important tool to separate cartilage from fluid, since both cartilage and joint fluid are anechoic, same echotexture, and sometimes difficult to distinguish, especially in children who have a very thick cartilage, much thicker than adults. The interface sign is visible if the ultrasound beam is perpendicular to the cartilage, as shown here in longitudinal ankle imaging in a 35-year-old normal volunteer who is asymptomatic with a slender ankle. So here would be the tibia, here would be the cartilage dome lined by a small stripe of black cartilage separated from fluid on top by the interface sign. Please also note that fluid is much more visible here in relative plantar flexion because all the joint fluid is pushed back into the tip-tail's joint space and accumulates there. In contrast with increased plantar flexion, joint fluid is much less visible. It gets more distributed in the joint. Although not shown here, please be aware that this is also true for other joints. For instance, in the elbow joint, fluid is more visible in the olecranon fossa in flexion, whereas in extension, fluid is more visible anteriorly, be it in transverse or in longitudinal axis. In the knee, flexion-extension maneuvers will change the amount of fluid visualized in the suprapatellar bursa, and I refer you to part 1 of the module where we have this depicted in a movie. Another important tool to discuss is the assessment of abnormal vascularity by use of the power Doppler function, and I emphasize power Doppler since color Doppler will be much less sensitive. Normal is an absent power Doppler signal. Normal soft tissue and normal microvascular flow will not be detected by power Doppler. Therefore, the presence of any power Doppler signals indicates abnormal vessels, abnormal vascular flow, vascular remodeling, and inflammation. This is clinically important since abnormal power Doppler signals and vascular remodeling have been associated with bleeding, perpetuated bleeding, and rebleeding. There is evidence that abnormal vessels in hemophilia are fragile and leaky. There is also evidence that abnormal power Doppler signals in the joint are linked to high blood pressure in patients with hemophilia, so it is good to check blood pressures. So apart from being useful in distinguishing joint effusions from soft tissue as explained in part 1 of the module, the presence of power Doppler signals may influence management decisions. For instance, adjust clotting factor regimen, administer intra-articular corticosteroids, synovial ablation, anti-inflammatories, joint aspiration, and other. To close the loop on the power Doppler function, I will present two cases, case 8 and case 9, both patients with persistent bloody effusions and persistent power Doppler signal requiring treatment beyond clotting factor adjustment in terms of synovial ablation, be it by embolization or steroid injections in these cases. So case 8 is a severe hemophilia B patient with chronic elbow pain. He's 55 years old, and you can see here in longitudinal anterior axis the elbow joint with an effusion, partially compressible, but also soft tissue fronds that are reminiscent of lipoma arborescens. In longitudinal posterior imaging, you see the olecranon fossa here filled with complex material, but also a profoundly abnormal power Doppler signal, indicative of abnormal vascularity and inflammation, probably leaky vessels that maintain the effusion. And very similar here, this is a patient with severe hemophilia A and fluctuating knee pains. He is 42 years old. Imaged here is his lateral recess, and you can see that the space is filled with a large effusion, compressible, as well as lots of soft tissue fronds, most likely also lipoma arborescens, with a vastly abnormal power Doppler signal here in the synovial area. Thank you for your attention. This concludes Module 2. I hope that Module 1 and Module 2 in combination have provided you with an overview how to diagnose joint effusions, how to distinguish bloody from non-bloody effusions, and how to apply assessment of vascularity by power Doppler signals in your clinical practice. If you like, please join us for the third module focusing on muscle bleeds and how to distinguish iliopsoas from hip bleeds.